Okay, good morning.
This is VL35.
Yeah,
Okay, we're good,
everybody can hear us and see us, and our both faculty and moderator friends, Dr. Murli Dharan and Vinod Kumar,
Good evening.
all there. Welcome from
Good evening,
Mount
sir.
Sinai. Bilkul, good
Pleasure
evening
to
and
see
good
you this
morning
morning,
from
sir.
here.
It's a pleasure to see you in this morning. Here,
Fantastic.
a pleasant evening.
And I'm sure I have visited our lab here, both of you, and many familiar faces. And we'll start with this case. And thanks for this MEDIQUEST, this opportunity to continue educational series, which we always want to do with my partner here, Dr. Kini, and we'll be showing this patient of the long bifurcation lesion. With that note, we have our fellow, Dr. Ayush, and rest of the staff if okay, we start our presentation. So this is the case in collaboration, which we will continue our educational mission. And of course, the disclosures for both of us, none. And Dr. Murali Dharan and Vinod Kumar, I just want to talk briefly about both of you. Dr. Muralidharan is the professor and head, Department of Cardiology at Sri Ramachandra Institute of Higher Education and Research and University at Chennai, Tamil Nadu. Very accomplished guy, great teacher, and we are so thankful for his guidance, and a lot of our faculty, our Indian colleagues have learned from him. He's very active in various trials and awarded numerous recognitions as shown there in the slide, and has been now the joint organizing secretary of Cardiologist Society of India in 2022. Now, Dr. Vinod Kumar is associate professor and consultant and also at same Sri Ramachandra University, Chennai, and has been actually visited our lab a few times. Very expert interventionalist. I call it a budding interventionalist, and doing all the complex cases, and also academically publishing. That is what I will tell everyone, all our fellows here. Like this morning, we had a research meeting that you may be good clinically, but you need to show it, prove it, and be approved or recognized by the peers. And that you can only do in the academic format, that you have peer-reviewed journal, publications, and so, besides presenting in various meetings. So clearly, welcome both of you, Dr. Murali Dharan and Vinod Kumar, for this today's session.
Thank you, sir. Thank you. It's a
Oh,
pleasure to be with you this morning. Thank you very much.
beautiful. So after our case, I saw I would say a scary title, Legion Yields in a Lethal Way. So let's see what it will be. After a 1 hour presentation, this will be half-hour discussion. After that, we'll interactive panel discussion. Coming back to now case presentation of episode 23. Now in collaboration with MEDIQUEST, 50-year-old female presented with new onset angina and ischemia. And patient actually had a few risk factors as shown there, but more importantly, no prior history, near normal EF, and had a multivessel ischemia, and had a cardiac cath. And cath basically showed the totally occluded circumflex and LED diagonal bifurcation with a syntax score 28. The patient was referred for cabbage outside, but they really, after discussion, didn't want cabbage and looked for it and came to us for revascularization. And that is what we did. So this is the case you see here. The proximal circumflex, you see that, done on August 19th, totally occluded, LED diagonal, some calcium in the LED. You can see diagonal will show a little better cranial picture today. So CIRC basically just wired it, require Gaia 3 to recanalize, and see proximally, we just put a one stent, Sky point 3023 with excellent angiographic results. Patient went home next day, and now here for the stage intervention of this long LED diagonal bifurcation lesion. Now question is what to do with the Dr. Kini will talk about the mini crush technique of the long lesion. Should we do rotational atherectomy? We may guide it by imaging, because angiographically only moderate calcium, and so appropriateness point of view, which we always present all our cases with the appropriate use criteria, OC of one vessel disease. This patient with the LED involvement, proximal to mid LED, and on dual antiplatelet, dual ischemic therapy. So more than anti-anginal drugs, so it's appropriate to do intervention. So with that note, Anu, show it now where we are. How does it look? Let's show the angiogram.
So I'm going to show you. Yeah, no. I want to show you. If you see with the LV gram, normal LVO,
Yeah,
and we don't see a lot of calcium in the LAD.
Right.
Maybe just speckles, which
Yeah.
you're saying are probably only mild.
mild to more. Yeah, yeah,
Angiographically.
yeah.
This is the right coronary artery. The stent looks okay, and moderate, about a 30-50 lesion in the distal RCA. This is the left side, circumflex looks okay, and you can see that actually there is diffuse disease everywhere. So this is our culprit vessel for today. So your mid LAD, which is significant disease, as well as diagonal, which is diffusely disease, long diffuse lesion.
So now question comes is like looking at it here, some people may say that, you know what, LED, I would say very clear now. You see only with the cardiac motion. So it's a mild calcium in the about 1 o'clock position. So it's a mild calcium. So no rotational atherectomy.
We could do
Those
it without.
devices, atherectomies are only for rotational or orbital or even for that matter IVL for a circular severe calcium, which is the tram track on both sides. Now, the question always comes, although patient has a clear-cut septal and apical ischemia on his stress test, but this kind of lesion, we felt that will be reasonable to show and maybe take the vote from our audience that will the LED be positive. Diagonal, I would say everybody agrees, 90+% lesion comes all the way up to the ostium,
Him to show me
and once
also.
we try to do it will be
Both of
clearly
us
will be
need to be
positive.
seen.
So let's say the LED, we should try to do a FFR to show even we have a positive ischemia. So what do you say, think, Dr. Murali? And Vinod, your opinion on this while we are getting ready to do the FFR of the LED. Because LED looks long segment, but moderate lesion. And we actually published also what are the predictor. This kind of lesion, which I had to predict, I would say this will be a positive on FFR. But you had to prove it. And your opinion?
You need one help. However, I saw the image, but it's very small. I request the admin to make it larger, your presentation screen. But I feel, as you said, it's going to be positive. That's my prediction, sir. But I would like to persist with so far also to confirm the same. But I feel it's going to be positive.
Yeah, very good point. So,
We make the screen larger, the presentation screen admin can make it, so that we can see little enlarged view of the angiogram.
okay. No, but can we enlarge the view of the angiogram any further than this?
No.
So is
Well,
maybe
it
on
looks
your
like
screen? No, could it be on your screen? What about Vinod Kumar? Vinod, is your screen angiogram is large enough, or it has to be enlarged
now
in your?
Now I
No,
got
it
it.
is okay, sir.
Now it is
It
okay.
is
Now
okay
it is
for me,
okay.
sir.
I see.
It is
Because
okay for me
here,
also. I got
yeah,
it.
because it's with the split screen, this is the maximum we can see. It's a 60% usually the angiogram, and 40% is the second view. So this is what we have at present here. So we'll ask our audiovisual team if it can be enlarged any further. We'll ask their help.
No, tell him this should be the camera showing us. He's showing it from that camera, I
Yeah.
think.
Okay. Let's go.
This one? No,
Yes. Yeah, good. Yeah.
wrong.
Yeah. Okay. So we are ready with the doing the FFR here, and we are ready with the adenosine. Now, many of these cases are the resting positive, so you don't need the hyperemia. And I know that a lot of people do IFR for that purpose. Yeah. Go.
Good.
Yeah. Are we okay here? Set.
Yeah, not ready. They took it before he was ready.
So they're getting the morning little lag inertia of the machine. Machines are sleeping. We have to wake them up. So meanwhile, let's
ready?
ask your strategy point of view. That what will be your strategy? Both of your comments. Let's say FFR of the LED positive, and diagonal, of course, is positive. So how would you deal with these two lesions?
It's not working.
And we can ask our audience also. They can ask some questions in the chat box and so. So Vinod, how would you deal with this lesion?
Sir, I feel strongly the lesion is going to be positive for
Right.
because it's a long lesion, sir. It looks like little calcified also. So once it has become positive, then we can wire both the lesions. Then pre-dilate prepare diagonal first. Then we can stent the main vessel. If probably we have to go from beginning with the two-stent strategy, sir. That's what I feel, sir.
Yeah. No, I also, Vinod, maybe you can, your audio visual is have a lot of reverberation.
Hello.
Yeah. So maybe you need a little, your audio visual is quite reverberations. Many times what happen is that maybe go out and come back in or so, because with the, and make sure your
Sure,
connections. But
sir, I
yes,
will do
yeah.
that.
Yeah, yeah. See, it's still a lot of reverberation. Yeah, so understood. So now, but the question is, let's see the technique point of view. Knowing that the lesion is always up to the ostial of the diagonal, and at that level, about 30, 40, I mean 50% lesion in the LAD. Anyway, let's see this now. And this, as you've also predicted, I predicted that it will be a positive. So let's see this now.
Don't
Okay,
touch it.
what we have now?
No, they take that other FFR wire out.
Okay. Now what is this? Rotor?
Yeah, rotor wire.
Okay. Okay. Now keep saying what you're doing now.
I think I'm trying to get, okay, equalize. Yeah. Okay, needle is out.
Show the screen also. Hemodynamic screen, please. Yeah. Okay. Equalized. Yep. So are you doing more IFR or FFR? I know the whole country is split here in America. Lot of centers have gone completely IFR, clearly with convenience point of view, avoiding the adenosine cost and so. And we still are basically FFR dependent lab. We do use IFR, patient with a aortic valve disease and patients who are on at least 2 bronchodilator. So in those cases, we go with IFR, otherwise routinely is done as a FFR in Mount Sinai. So tell us your experience.
So our system, actually, we do have a Boston system which uses IFR, DFR, and FFR. We have made even a small study also then for publication, but though we do DFR, we don't stay with that. We are thinking we are the learning part with DFR, so we completed the FFR. The correlation seems to be good, though our number is very low. We see a good correlation between DFR and FFR in our own experience in our center. IFR we do rarely when we get the system blended to us through the vendors. Most of the time we do DFR.
Okay. Very good. So RFR, DFR, and all those indices are now. So we are starting, as you see, the resting is 0.9 and double dose. Yeah. We started the drug now, and usually once it is positive with hyperemia, it takes about 2 minutes, less than 2 minutes to become. And anytime when it starts at about 0.89 to 9, my prediction is usually positive. They start at 0.95, usually it's negative. And also the guide should be a little out of the ostium. Yeah. 0.3, 2, 1, 0. Okay, stop it. Yeah. Very quickly became positive. Yeah.
Okay, where to? Let me pull back to understand.
Yes.
Pulling back.
Yeah. Very, very clear.
Very clear. Yeah.
Okay.
We expected that, as you predicted, I predicted, and we actually have a paper in Euro intervention. One of our fellow, we did evaluate in the intermediate lesion 40 to 70% predictability of FFR positivity and LAD, the calcific lesions and length of the lesions. 3 were very important. So LAD largely because of the myocardium it supplies. So those are the 3 important predictors. Okay, let's start with the balloon. No, let's do the diagonal. 2.520 and LED 3030. Definitely there is a calcium in the LED.
Sir, what is your choice, sir? IC or IV? What do you prefer, sir? Do you have
No,
any?
we do IV. No, but remember, most of the study is still being done with the IV with the 140 microgram. And if you are concerned with hyperemia, you can increase the dose by 30%, make it 180 microgram per kilogram, but otherwise 140 microgram per kilogram still remain standard. Now, we can do intracoronary, the injection of 120 microgram or for the left side and 60 to 80 on the right side, but that we don't use at all. So all are done with the intracoronary, intravenous, not in the intracoronary. Because most of the data are of those anyway to support it. So before all the FAME trials were done, they're all done intravenous. Actually, earlier FAME, they used to put a center line. But now nobody does center line, we just do peripheral. And that's good enough. You have to just wait a little extra to flush and gives a very good results. So now this is the run through wire has been put into the LED. And now side branch in the diagonal, we are going to insert the fielder wire. So that has been our choice. The LED diagonal bifurcation, main vessel go with the run through, that's our workhorse wire, and use a hydrophilic wire in the side branch, particularly very tortuous diagonal. Yeah. So clearly this does not need a plaque modification as because of the calcium we have spoken about, but the issue will be and then we'll talk about the bifurcate 3D app. I know it has been shown time, but a little more detail about this kind of strategy, that what will be predicted based on the bifurcate 3D app, that what type of strategy we should be using in this particular case. So complete, Vinod, you are saying, yes, we dilate both of them, then to put two stents.
Dilation strategy has to be very clear.
Yeah.
That we always dilate the main vessel. Just to, there'll be definitely plaque shift when we do the main vessel dilation into the side branch. Now trying to get into the distal part of the diagonal, it's not going, but that's okay. We can just leave it there. Just be cautious.
Yeah.
So we're going with the 3030 balloon to the LED.
Side branch. No, okay, do this.
Hello.
Main,
Hello, where
fine.
are we
Yeah.
going?
Yeah, so
Yeah.
this is 3030?
Yeah,
3030. Okay. So question was very important, that once you have LED, any bifurcation, two vessel you are intervening, and if you are going to put a stent in both, probably it's less of a matter that you dilate which, but you definitely want to dilate the tightest one first. But if you're using a
Provisional.
provisional stenting approach, then the side branch should be dilated last because of the plaque shift otherwise. So that's the key. So now a lot of people still do a kissing balloon dilatation when you're planning to do a two stent strategy. I think it's not needed. This is a 3030.
Okay, down.
Yeah, it opened up at 12 atmosphere.
What have I dilated too much, I guess. Okay, 102.
Okay, good. Going up.
Okay.
Yeah, we actually don't have a 48 millimeter Zions in USA. I know it's freely available, Giants Expedition in India, but we do not have a 48 Zions. We are actually Zions, long Zions trial we just completed, and we do have the 4.5 and 5.4 Zions, same synergy also. And clearly that now the diagonal is looking pinch, which is okay. Yeah, let's go to the diagonal now, 2.5.
Maybe too big. 2.5.
Huh?
2.5 maybe too big. It's like 2 to 5.
Okay, we get a 2 to 5 balloon.
No, you have a 2.5 already opened? Don't you think it's too big?
So we can use a 2.0 even. The question is, what
So
size is the diagonal? Yeah.
So what's your plan for the mid segment disease of the diagonal?
Yeah, so we had to go for, all the way that distal segment, yes.
Yes, sir. But is the vessel that big, sir? Well, my question is, would you like to stent it or would like to think of a DEB?
No, this case we want to do a two stent approach and bring all the way from the mid segment to the ostial. So it's a large size diagonal. I mean, yeah, I know it's a 2.25 vessel or just in that range, but it's a large size diagonal. And we felt that in order to have a good results, that this is the case
So
you'll
what
do
you
a
want,
mini crush.
48?
Yeah.
3 or 48?
3048 and 2.5 here. Yeah. This is the 2.520
I think maybe too big, no?
for the
2.5
diagonal.
to the diag. Stent.
The low pressure will go.
What's the 225 you have? Or you want to put 25? 25.
So it looks like if you do a
48
stent,
synergy.
you may need a
You have
two
48
stents.
signs? Yeah. Exactly. We don't have it. Yeah,
2.25, 48. Yeah. Yeah, both 48s.
No,
Okay.
not for the diag. It's too long.
Huh?
Too long for the diag.
You need 48. You need to go
Okay.
distally.
Okay.
Okay. Yeah. All right. So this is the 2.5 will be a low pressure.
No,
It may be a.
dilate it.
Uh-huh.
Yeah.
Opened up at 10 atmosphere. Yes.
Okay, down.
So anti-platelet therapy, usually in this young age, I mean, anybody who has a CTO, we try not to put a stronger P2Y12, which, so if, last time we just did the clopidogrel, and patient went on clopidogrel, right? We didn't change it to a prasugrel. So yeah, this is the case now. After our intervention, we'll
Go for the osteomasis.
we are going to switch this patient to prasugrel. I know a lot of people
What is she on?
use.
She's on Pasogrel.
Yeah, that's what I thought.
Yeah, down.
That initially when patient came, we put on clopidogrel before the CTO recanalization. After we are done, and you give a loading dose of clopidogrel, then you give 30 milligram load, and then discharge based on the weight basis, 5 milligram. Majority of cases less than 100 kilo, we give 5.
Go. Okay.
Yeah, go a little
opened up
distal or
good.
no?
Yeah, we have to open that.
Yeah. See, distal lesion, it's a long lesion, maybe require 2 stents in the diagonal.
No. I think 48 may cover. I was thinking even 38, but now
no.
I think we're okay.
Yeah.
Okay, open 2548 and open it. Yeah, good.
Good.
Down.
And yeah.
Yeah. And 30.
So coming back to the point, so if the CTO, we will go with the clopidogrel load, and then after recanalization, we switch. If you want to give whether Brilenta or prasugrel, then we give 30 gram load, and then 5 milligram, unless it's more than 100 kilo, we put a 3 stents. So that's basically our strategy. And in this case, so that initially we give clopidogrel, then patient was discharged on prasugrel, and I know the slide will update that. It's 5 milligram. Now, once you do these kind of 2 long lesions, we, despite the weight, I would say that we'll give at least for 1 month prasugrel and then change to 5 milligram. So a lot of studies have shown that maybe de-escalation is good enough. So this is now 2.25.
We can put a side-by-side bifurcate.
Yeah.
You don't need to show us, but just my hands. And there you can put the bifurcate, mini crush, side by side. We are going to the side branch first. Always the difficult vessel, you will place the stent first, but most likely it's side branch, more angulated. In the rare situation, you may have to place it in the LAD, because LAD could be angulated than the diagonal. So we're going with the 2548.
That's the case in room 2. Amit Huda. Yep.
Okay, 2548.
It's a
going into the
2.548 Synergy XD. Yeah. In the side branch. And then we have a 3048 for the LED.
Okay.
Too long stents. I know a lot of people think about we can do a spot stenting in the DES era, but then it will require your lot of multiple IVUS runs. Yes, area has been opened nicely. Yeah, it looks like it maybe 48 is really too long for the diagram. But let's see if we can go a little more. Yeah, yeah. Yeah, a few millimeters. No, it's okay. It will be all right.
Okay, now the wire went to the distal branch.
Yep. Good.
So you park it a little distal, because now we have to place the main vessel stent. So once you've done that, you connect here. Hold it with your other 2 fingers. Good. And always keep cleaning the wires. Keep cleaning the wires. You can get sticky when you have 2 wires. Entanglement, very common.
Yeah, I know the
If there are any questions, we can ask the questions on the chat bot.
So encourage our participants to ask any questions. So we have done now the 2.5 into the diagonal, and now we're going with the 3.0, 48 Synergy XD. So a little different than what's available in India right now. India is only Synergy, and XD basically is the better delivery system. And then for the large vessel, 4.0, 4.5, and 5.4, we have the Megatron. And Megatron is basically extra. The connector in the proximal part and thickness of the proximal part of the strut, and that's good for large vessels and the ostial lesions.
Okay, so you see that 1 millimeter of the side branch is sticking into the LED. Go.
Yeah.
Okay, good.
Yeah, looks very good.
It's too much.
No, looks good. Why?
Yes, okay, go up.
Yeah. Okay, diagonal we are going up. So clearly side branch first.
Always you have to put a sticker,
Yeah,
my
yeah,
friend,
so here.
so we understand what is
Yeah.
what.
Good. Okay. So this one I'm going to go just knowing the vessel is just 2.25. So we're deploying at 10 atmosphere. Usually we go to 16.
Okay, good. Down. Go up again. Why you didn't give us a connector? Different. Okay, good. So now I'll take the SDS out. Slow. You see that there's movement of the guide, but that's okay. Yeah, give some dye. SS. Let's make sure we are okay. Don't touch anything else. Yeah. Okay.
Yep.
To us looks fine. So I'm going to take the side branch wire out. So the LED has not moved. Okay. So
Yep.
we're going up the LED stand.
Going up now.
Yeah. Good. Go up.
LED will go say use your deployment pressure of 16.
Get down.
Now mid may need to be redilated now. We have the balloons anyway. But to go to the diagonal, now you need a new balloon with a lot lower
2012.
2012.
Yeah. You have
Before
it.
you
Yeah.
go into your what we have done before.
Okay. Down.
Because clearly don't struggle. Use balloon will be very difficult. You're going to put a wire, push the wire, so and so forth. So once you're done, except for the left main, I say that do not go with the high pressure balloon again till you have opened the side strut with a small compliant balloon. So our usual is the 2.0.
So we'll take both the, and then we'll see if the same wire will be able to recross into the diag. Once this is out, we'll take a picture now.
Okay, let's take a picture.
Hold on.
Pull the LED wire a little bit. Good.
Okay, looks good.
Good. Let's recross now.
So same wire, the wire is in the guide, if you can see that. You don't have to take it out, it's in the guide, and I'll try to recross with the same fielder wire and then get 412 balloon ready.
I know so a lot of people say that now take the LED wire, go into the diagonal, and so we usually go with the same wire which we had originally. But the whole purpose there is so that you're not behind the stent struts and that concept. But you know, you'll know it if you can always do put the diagonal wire first into the LED, pull back, and then go to the side branch. So that is what I know a lot of people in Europe teach. That now you should take the main LED wire, a main wire of the wire of the main branch, go to the side branch, and then put a side branch wire into the main. But we do not do that practice because I think it's reasonable as long as you have gone to the main vessel and then you pull back and do it. Good. So now has been done. So this is now 2012 compliant balloon to open the ostium. Before we do, advance both our high pressure balloons which we had before. We are going to use the same one. So now you see the angiographically looks great. Long lesion, long vessel, diagonal still remain tapered distally, but has grown up quite well. Mid segment still looks like a little narrow, but that may be because proximal segment of the diagonal is a little too much, and little crush only at the ostium.
If it does not go, let us try showing balloon anchor. Okay.
Hmm.
Now that I'm not happy about.
So now in the app, you can see that if this does not cross, you have various options. You use a new balloon, which is a small
No,
2O
there are various options.
to
Recross.
the main vessel
Okay.
balloon,
Recross.
3O. Yeah.
Now recross, or we also say if you want, you can do the pot of the proximal vessel and then. But here, the vessel is well optimized. We don't need to do that. Other option would be to do balloon anchor, and that's what we want to do. So we are showing the balloon anchor there.
Connect, yeah.
Andrew, show the balloon anchor.
So knowing that we already have a 3O balloon in this for the LAD, we are going to go back with that. It was a 3O30. Huh?
What is this? What is this then?
25 is okay. Yeah, good. This is okay, 3O.
This is 3O?
Yeah. Yeah, 3O. The LED balloon, we are going back with that now. And we go negative. Because this balloon has been used. So I know.
No. First go negative with the syringe.
Yeah, good. Go. Okay. So this is another technique that one, you go to a smaller balloon, but here right now we are ready. Okay.
Go up.
Yeah, we are within the stent.
Yeah,
Make sure that you are within the stent. Go up. Yeah.
So we are within the stent, anchoring it. Go.
8, 10, 12. Yeah,
Okay.
good. Yeah,
Now
and
you
see
see
that
that
right
it
away
went
went in. So no struggle. No pushing too much to take the wire out, push the guide. No. Here you
Go,
just
go.
basically recover little anchoring and it went in. Now you can open nicely with 22 atmosphere. It's a 2O compliant balloon, deflate now. And we are ready for bringing the diagonal balloon, which we had earlier, 2.5.
I want to do that.
We can take it out now. Leave this one there.
No, this is you want to do
Yeah, diagonal.
2.5.
Yeah,
I
good.
have to go back in.
Want to make sure it goes in? Yeah. You want to go to the distal edge? This 2O balloon very
Yeah,
further
yeah.
down. Yeah,
Okay,
good.
go up
Okay.
there.
Yeah.
It is not going there. That's distal,
Yeah.
distal. I need
Yeah.
down.
Yeah.
Wait 1 second.
Yes.
Because our stent may not have completely dilated here.
Yeah.
Okay, good.
Good. Okay. So edge.
Yeah, go up there. High pressure. So you dilate it. Yeah.
Yeah, there it looked like that stent not fully
Did not
dilated, but
expand.
now it is dilated.
Okay. Now you know what? I want this back.
Okay. Good. All right.
So we'll go with the 2.5 to the ostium of the diag, high pressure and kiss at the same time. Yeah. Now, if you go back, Andrew, are you showing that balloon anchor? In that animation, you can see what the mechanism of balloon anchor is. That is, you have dilated the balloon in the main vessel. So ideally, we should place it within the stent because you want to go high pressure. So because you're anchoring, so what does happen? The guide is stabilized. Once the guide is stabilized, then your side branch balloon able to navigate through the proximal part of this LED stent and get into the diagonal. That is the mechanism, and that's, I think, well shown. You can keep watching that. Why we have to do this balloon anchor? This will not go. Give me a new balloon.
It will go now. It will go. It will go. Yeah. So and then of course the part of the teaching to all, we have biggest interventional program in United States with total of 14 fellows in various capacity with 8 negative. You need a negative.
That's now you're not gonna get to. Okay.
And so we keep teaching, and we have 8 our coronary fellows, then 2 endovascular, 3 structural, and then we have 1 the hybrid fellow, and we actually have right here Vishal.
Let me go in first. You may not go.
Good. Go. Yeah. Your wire in the LED. Yeah. 1 second. We can do anchor again. So put the LED wire. Good. Put the LED balloon further. Yeah, good. We are there. That's fine. We need to open a little bit.
No, this is 30 balloon is not going now.
Okay, we can do all. Let me go a little negative. Go up low pressure. 1 second. 1 second. Yeah. So just open that lumen. You'll make a room. Low pressure will be okay.
No, the LED 30 balloon is not going in now. That's the
Okay.
issue.
So
Remember,
what we
I
do is
did
okay.
not
1
want
second.
this.
1 second. Okay.
Give me a new balloon. 2512 high pressure balloon. Yeah.
So LED balloon was in the. We are going to go back again, and what we do sometimes is the voice technique by our Indian colleagues. They're decreasing the profile. They go inside high pressure in the guide catheter and then go back in. So let's go to the LED again. Let's see if LED goes in or no.
30 balloon, I think you cannot go it, and I think let's not destroy anything.
Okay. So what do we need now?
Just give me a trio new balloon, 15.
20.
Sir, there's a question from Dr. Kashyap Prasad
Yes.
about why part is not done.
What part?
Pot?
Pot, yeah.
Yeah. No, but question was the same. That remember, I know we do a lot of pot, but without any scientific basis except that data more for left main. Remember the pot pro trial was no benefit. So here, I don't think pot will do any different than just doing the kissing balloon. We'll do the kissing balloon, but yes, the only indication from our point of view
What
for
is
the
this?
pot.
Trio?
This is what? Trio, yeah. The pot will be in this particular case if you cannot get into the side branch. So your stent are nicely open. Yeah, that will be the only one because I know we all want to do pot, but where are the data? Randomized trial of pot pro did not show any benefit. Actually, in the compared to kissing balloon, they found more mal-opposed struts with the pot versus kissing balloon. So I think kissing balloon probably is the best way. Now left main is a little different because of the size. And here we have done the 3015 now, the new high pressure balloon, and we are 2.5, 15, 12. A high pressure.
I
So we are
fully
going with the
agree with
new balloon. Yeah.
you. I fully agree with you. Vinod is with me. We rarely do part. As you rightly said, we do part only specific circumstances in our center also, sir.
Yeah, exactly.
So especially when you're doing the bifurcation, I think the steps that we teach is very important that you follow the steps because every extra step, you see that there's a need for entanglement. Even this one, you see now we are having issue with any of this balloon
So
going
let's do
forward.
the same
Okay,
anchor.
go, anchor.
Yeah. We're going to do anchor with the 3 balloon of the LED. Good.
Oh, no.
Okay. So what we'll do is bring this balloon back at the level of the diagonal, open at the level of diagonal, because going through we probably destroyed part of the stent start here.
Go.
I'm going back up. So this is kind of a modified part.
What is okay, down.
So 2 went in very
Okay,
nicely,
go up here. Yeah.
but the 2.5 is the one giving us trouble. One initially we used the old one and then the new one, both of them
Can you give me
compliant then.
compliant?
Yeah.
And track 2.5. Yeah. Track.
Okay. So question was that when 2 went in, why the 2.5 will not? I think it's all the profile, and one was compliant, one was non-compliant. You expect that by opening, you should be able to get through it, but same. If you could not, I know the choice is always opening any balloon is extra cost to the patient, but we also need to be cognizant that pushing too much guide, multiple movements will cause more stent deformation and will create more trouble on the long term. In this case, after we are done optimizing long lesion, so that this is the case I would say will benefit from the final imaging. So we did a physiological testing before and the final imaging to optimize our results. Now wire in the diagonal is little.
No, that's okay. I left it like that. Okay.
Good. So compliant goes quite easy. Go. Good. Okay.
Now,
Let's bring
when
both
you
of them.
have the wire, that's the way it looks in the distal part of the dag. Don't go into the vessel because I'm within the stent.
Yeah.
Because if you take that wire down, 100% wire perforation.
Good. Let's pull this one back. LED.
Oh, wait. Good.
Good. Okay. Going
Okay,
up,
let's go, Chris.
both 16 atmosphere. The diagonal can go a little higher, 20. Is a non-compliant. Good.
Okay, down.
Now, question
Sharma
always
sir, the
comes.
question to the audience.
Hmm.
Sharmaji, the question of the audience, why did you choose
Yeah.
DK, mini crush or DK crush?
Mini crush or DK crush?
Yeah.
Yeah,
That's a
that's what the
very good
question.
point. Yeah. No. That's an appropriate question and very important question. And we say that you need to come develop a technique in your lab yourself, what it works best for you, and just keep doing the same. So our lab, we just do a mini crush. We even left main. Our 90% of the left main, we do a mini crush. DK crush will use, particularly get a new fielder. Particularly
No, I
when
don't want.
six
They're done.
French. Yeah.
They're done.
So IVAS will do is so we do mini crush because same that I think the issue of the DK crush and so it still need to be more because multiple steps. Yeah. Beautiful. See that? So question, I think that mini crush take away some of the steps what the DK crush has, and we are very happy with the results. So as I said, in our lab, even left main will get by definition, the majority cases get the mini crush compared to the DK crush. So one of the important indication of the DK crush in our lab is when we are doing a radial or 6 French. So there, DK crush you can do through the 6 French, but for the mini crush you will need a 7 French. But we are just,
Actually,
somebody wants to do a DK crush, there's nothing wrong in that. That is okay, approved. And we just need to have some more data out of China on the DK crush point. You know what I'm saying?
No. There was never a comparison of DK crush with mini crush ever. Yeah.
Yeah.
It was always with provisional stenting or culotte. So, I mean, all our live cases, we have been showing this technique, even with imaging, to see, the results are very good. And despite us saying the steps have to be the true, so there's still a lot of entanglement. So good.
That's good.
So what do you see that it would not go? So I just reoriented the guide in such a way that we were able to get the
Put the IVAS on the main screen, please.
Still interested, it's okay.
Okay,
Yeah,
that's fine.
that's fine.
Now it's come to the native. So I start fullback. Yeah, it's this a native. Some blanch. So normal part, healthy vessel. And proximal, yeah, big vessel, getting bigger. The left side. Yeah, looks good. Can you flash a little bit?
Left.
Okay,
Yeah,
just make
now
sure
it
this one-
looks expanded. Yeah, well expanded. Looks like no calcium outside. Well expanded.
When you're at the level of the diag, if you see it, okay, make
Yeah.
sure you're not there
I
yet.
saw some small chunk of calcium, but it looks well expanded.
Yeah.
It's gonna be
Fully
long
opposed.
stand.
Yeah, that's a
Yeah, I can check the area later, but it looks good. Yeah, long pullback.
diagonal.
I saw
right
some
here.
Yeah.
bunch. Yeah, okay, sorry. This is a diag.
Okay.
Come to the
But
plot
now
already.
you just see,
Okay, looks like
just with kissing balloon, we are able to get a full
yeah. So yeah, looks like
full
upward.
expansion, fully opposed, and no dissection proximal or distal.
Yeah.
Go to caudal
Yeah.
view.
I also saw the sucks and really stick to the bifurcation.
Okay. I'll take out the wire.
Yeah.
So we just give some vasodilators and have the final picture.
It's on the
So
plot.
always teach in complex cases just a low mag without moving the camera. Take the last picture.
So biggest worry always of the side branch, since you wire, rewire, it can go to small branch, risk of wire perforation. So, long cine, document that there's nothing there.
Yeah. So from interventional point of view, with the aided, finally aided by the imaging, we got excellent angiographic as well as imaging result in this particular case. There's no change in the electrocardiogram, patient not having any chest pain. So we are complete from interventional. So if we can go to our the presentation back.
No. I just
Yeah.
want to make one very clear point. Remember, normally we teach it. You cannot have the wire the way it is in the diagonal side branch what I left, but I made it clear that time also that you are okay because it's within the stented portion of the vessel. Don't take this U loop to the normal vessel, because if you go further down, it will go into one of the small branch and will cause wire perforation. So there's a very important key learning point here. You have to follow that strictly.
And with that result, and you see it, the final results came out excellent. So now these are the various app, 64,000 plus with the download, and we felt that talk a little more about the bifurcate 3D, which part was shown actually side by side during the
Yeah, that
deployment
was
here.
a thing. So a lot of people asking about why not DK crush. Like we said, you just familiarize yourself with one particular technique and keep doing it. DK crush definitely has extra steps, and whenever there is extra steps, crossing, recrossing with the wire, the important thing that we see is wire entanglement and the distal wire. And when you're advancing the wire stent, all these things can give rise to proximal vessel dissection, distal vessel wire issues. So try to minimize the step. That is I think the key part that we are trying to show here. So our initial app was bifurcate, which was just the illustration, just side by side illustration how you can do it. So we thought we can do some animation and exactly show. I think the important point we exactly showed here is how balloon anchor works. What is the physiology behind the balloon anchor? So after we did our initial bifurcate, there were a lot of requests to just have a website, because many of the cath lab, if they don't have internet access, they could not access through the app, and a few people don't want to have the app on the phone. So that is why then subsequently everything that we created, we have a web app or the website where you can go. So this is a website, as well as we have the app that you can download either on your Apple or via the Google Play. So very important is various techniques are there, whether it is left main, non-left main. We
Done.
just showed you one technique, but
Bye
you
bye
may
to
favor
bypass.
something else depending on the vessel
And
size
whatever I did last.
and the side branch size. There are various techniques. So you want to just know the technique rather than go through the algorithm that we have created. You can just watch the key videos. So look at the key videos that we have created. And very important with these key videos that they are free to be downloaded. You can go to the website, and there's a very easy way to go there and download this, so that if you want to use it for your teaching purposes in your lectures, you can use them. So in a non-left main, mini crush, DK crush, cool out, tap, reverse crush. And we already showed you balloon anchor. That is what is called as a stent pullback technique, where you just have ostial side branch lesion. Years ago we published this, and also we have described in a rare situation when to do pot KBI. So all this has been described there. For left main, very important, same, we have shown the video of mini crush, DK crush, coolot, V stenting, which means you have ostial LAD, ostial circ, and mild distal left main disease, large vessel, you can do what's called as V stenting. SKS, we only have shown that you have a cardiogenic shock patient, very unstable, significant left main disease involving both the branches. That's the time we say that you have only few seconds to deploy and come out. You can just do the SKS technique in a left main patient and unstable and shock. That's the time we have said. So I think this one we already went through. I'm just showing, if you go there, you can see the videos, and other one is the app. So here we just showed this, that how you can do it very easy. You can see that simple, but you have side by side, it comes through saying that this is what you need to do. So always wire both, pre-dilate, and if your pre-dilation, you're not happy with your side branch pre-dilation, consider atherectomy, what you want. So that is where we are with this mini crush technique. So this is another one. I think balloon anchor we already showed you. I didn't want to go back and go over the balloon anchor.
Yeah.
What we are showing is that suppose you decided that you just wanted to do another technique, which is a provisional technique. So we're just telling you here. So You pre-dilate the main vessel. This is exactly what we wanted to tell you. Always do the same step for every case so that you know you will never miss that step. So that is why we teach our fellows here also pre-dilate the main vessel, because what is the teaching? In most of the cases, the treatment could be what? Provisional stenting, depending on the side branch. If the side branch is less than 2.5, go for provisional stenting. A lot of people don't even bother to do anything to the side branch. If you want to keep the wire, a balloon so that it remains open, that's okay. So you did provisional stenting and we know the side branch looks okay, you're done. But if there is any of the things that we mentioned, patient is having chest pain, EKG changes, or the flow in the side branch has changed, you got to rewire and balloon. And then once you ballooned it, you will also get the thing that do we have to do anything? This is what we did with the balloon. After ballooning, we may say we can just, stop here. Vessel looks good. If you think after you ballooned, the side branch still did not open, or you created a dissection, you have an option now. What can you do? Whether you want to do a tap technique or a reverse crush, and that's what we are describing here. Tap means a part of the 1 millimeter sticking out in the main vessel. Then you have to pull back both the side branch as well as the main vessel and do it. Or you can do what's called as reverse crush, where you crush this part and then you have to recross and kiss. It's very important you learn both this technique depending on which you want to do. This is if you are done provisional stenting and then you think you are going to do a bailout of the side branch. This is what it is. So all these techniques have been covered in this Bifurcate 3D. You can just, it's a like a textbook, huge textbook of just bifurcation, but everything is animated. And what we also have covered is in the basics, we have just gone through all these techniques and description of how to wire, when to do what, everything in just a PowerPoint short description. In the basics, you can go over guide selection and wire selection. That's about the Bifurcate 3D.
And this is your...
Yeah, total contrast used today is 120 with the air karma of 0.8, which is very good.
Yep. Okay. Any questions now from our faculty and or any audience?
Wonderful presentation. Thank you for showing a fantastic case. Lot of learning points. I have a question to Dr. Sharma ji.
Yes.
I have heard about your skills and presentation, team, everything from many of my colleagues, particularly Bhupati and Vinod. I have one question for you, sir. Yes. Among the bifurcation technique, when do you prefer? I know you don't do it regularly. You prefer DK crush or mini crush, as you said now. Yeah. When do you prefer culotte, sir?
So very important point. Culotte I would do as kind of a more delayed culotte, a small vessel side branch, and now patient comes back. So question there is, and your main vessel stent remain good. So I actually have a beautiful case. A patient came back with a 90% osteal circ, little long lesion, and we put a stent 6 months ago in the left main to LED, but that remained good. So now, and was little angulated. So question here is, you do a tap, you do a mini crush. So if there you want to be guaranteed, it probably culotte will be okay, but that's a delayed culotte. Acute culotte we do not do at all.
No, I will tell you what are his question is, when would you do it?
Yeah.
When you have, remember your very important is the vessel size. So usually side branch is smaller than the main vessel. In a rare situation, right? Let me tell you about non-left main. In non-left main, you can have a diagonal which is larger or the same size as LED. LED 3.5 goes and becomes a diagonal which is almost a 3 or to 3.25. Then after that the LED goes down, which is very small. In that situation, people can prefer culotte, where you're going to do from LED to diagonal one stent and see how it does. If the LED is still okay, you can leave it. If not, then you will go through the LED stent, means LED proximal stent to the distal LED and put another stent through that. That is for in the situation of LED non-left main. And in the left main, it all depends. You can do mini crush, DK crush, and Europeans prefer culotte. That they will go from left main to LAD, and then they'll go from left main to circ again.
So
So
in
it's
nutshell,
all your preference.
In nutshell, I think I still say that I think you need to master DK crush or mini crush. I personally don't think there is actually a need for culotte. I know it's the same thing. There are maybe operator who does 90% of bifurcation with culotte and they great results. That's perfectly fine. That's the practice. But to me, the culotte really gives more metal to the vessel. There's no question there. So we see few cases come from outside, lot of restenosis. Then it's a tough to treat at that time because there is a now double layers, multiple compared to mini crush or tap. It's very small. So as a generically, we discourage culotte. And some cases which Dr. Keeney mentioned, that side branch disparity, and you want to be fully covered. It's a little angulated. It's not a T. If the T, probably tap is very good. But if not angulated, you need to cover, then question things about too much metal versus what, probably better do the culotte. So a small percentage, if I take 100 cases of bifurcation, stenting in Mount Sinai, of the 100 cases, I would say 90 will be done with a mini crush, about 8 or 9 will be done with the DK crush, and most of those DK crush are the radial. A few percentage will be the reverse crush or step crush. Actually, we are going to show next Tuesday through the Lima, LE diagonal bifurcating lesion, and we're going to use a step crush technique. So those are few percentage, but majority 85-90% is the mini crush, very small percent of DK crush, and others are very, very rare. Culotte probably make it maybe 1 in 300.
Oh, thank you. Thank you for the explanation. Thank you, both of you, sir.
Beautiful. So with that note, if it's okay, we can stop. Sorry.
Some
Vinod, yeah.
Sorry, sir. What about imaging, sir? Whether it is mandatory in a non-left main bifurcation, or we can go ahead without imaging also, we can perform a bifurcation stenting. What is your take on it?
Yep. And you want to answer that imaging question? Routine imaging.
Routine imaging in Mount Sinai lab is not done, but routine imaging is definitely performed in every left main in Mount Sinai. For the last few years. Means for every left main, you have to be very careful that you are fully opposed the things. And as you see here, right now, the imaging with this current, newer generation things are so good. For non-left main, we usually do not do the imaging, and most of our imaging work is research related.
Yeah. So we have many labs do imaging, but I'm saying till it becomes class 1 indication, latest guideline of 2021, it still did not make imaging, even for left main, as a class 1, 2A and others 2B. So post to me, I think in the long lesions, it's reasonable. Left main, I would say almost mandatory. I thought that they should have made it for the left main, at least a class 1 indication that imaging to be done, but did not make it. One of the key, I would say those who are the leader in this paper, revascularization, is one of our attending in Morningside, Jackie Tamis, and I did ask her that why would we not make a left main? Enough data have accumulated, and I know even others also with the trials data of the Zions and other studies have shown for that clearly there is a benefit of not only in a long-term mortality benefit. All studies have shown. Why would you not make it at least in some group as a class 1 indication? I think the overall feeling was that this was a very heated topic, and finally the decision basically what made that let's keep it till more data comes, and knowing that some of the trials which are ongoing, Illumin and others, will answer that question. Maybe in the next reiteration they'll make a class 1. So coming back to your point, is it mandatory? No. In some cases it's highly recommended. Other, in my opinion, imaging is a luxury or a research item.
Other thing also we have to know, this imaging always comes with a cost of one, increase the time, number one, and things could go wrong while you're just doing imaging because you can't see it. You're flushing. When you're flushing, a little air bubble goes in, you start having slow flow, and now the cycle starts. So you need to know that. And for the question of a non-left main, soft indication, when I would say, from my opinion, is some people want to do osteal LAD, okay, once they have stented. If you want to do in a young person, because the person is young, number one, and depending on their employment status, if they are commercial pilot, number one, if they are still going back, and many of them in this country especially, the lot of people who ski, okay, and they're not happy of taking anticoagulation because of the risk of having injuries or competitive sports. So if a young person doing that kind of a job, that's important. And of course, high bleeding risk where you're done proximal LAD and there's a risk that you want to stop it at some time, or pre-op going for some kind of surgery where you're very comfortable, 100% you will stop it.
Okay, so Vinod, that
Sure,
answers
man.
your
Thank you.
question. Yep. So with that note, I know we are exactly on time, and thank you very much.
Thank you,
Thank
sir.
you, sir.
Thank you.
Great
It was
job.
great. Great
Good,
case.
good.
Thank you.